Okay, the plan for this is to go into a little bit more detail. And I'm wondering whether or not you would like to try doing some exercises with me in this. Let me see if I can see some nods in the audience. Do I see some people nodding? Okay, good. All right. So what I would like you to do is to find somebody that you are willing to talk to, like a pair, two people. So it may need a little bit of movement, all right? So when we get to that part, I'm going to ask you to talk to somebody. So like move a little bit, okay? But first of all, I'm going to talk about this model. And I use this model when I'm teaching people how to do it, right? This is not about all those big system issues. I'm really wanting to say, how would you do this in clinical practice? So what I would like you to do, and you can have these slides afterwards, is to say, if I was to be asked to teach somebody, this is maybe one approach. So you can take this approach and use it in your setting, okay? All right. Yeah, if you wanted to get in touch with me, this is my email and so on. I'm happy to for you to find that. It's very simple. It's Glyn@gmail. So this started with this paper, which I wrote, I think was 2014, which is about 12 years ago now, I guess. You know, shared decision making is a term that has become very popular, right? Very popular. It's used by policymakers, it's used by researchers, it's used by clinicians. But there's something behind the idea. And I tried to write about what is the deeper theory or model behind the idea. And I thought there are two things that are going on, two verbs that are going on when people do shared decision making. They, first of all, they work together. And the second thing is they deliberate. You probably know about Kahneman, the type, think fast and think slowly. This is thinking slowly. This is system 2 thinking, right? Not the system 1 thinking where you make a quick decision intuitively. This is system 2 thinking where, let me think about this. Let me take my time to think carefully. And that is called deliberation. So the two big things that are happening when people do this well is a collaboration. I get to know who you are. You get to know a little bit about me too. So we are collaborating. It's a genuine democratic process where I am interested in your views. And probably, I hope, you're interested in my views because I studied medicine, I learned about this, I know how to use science, I have some experience, but I'm also interested in how this is going to fit into your life. So we are collaborating. It's democratic. It's not about kings, it's about people working at the same level, right? Less power hierarchy. So that's really important. It's a collaboration. And then there's the deliberation bit, which is thinking carefully. And in order to think carefully, we have to do one very important thing. We have to recognize alternatives in the world. There's more than one way to do things. And often people who have low agency, who have not made other decisions in their life, don't recognize that they have agency. This is especially true about people who have low levels of education or have very low income. Because actually, if you have a life like that, where you have low education and low income, you don't have much agency. You're not making that many choices. The choices are made for you, where you live, what you can afford, what you can eat, a very limited number of choices. So in order to give people agency, you have to lift them up. You have to recognize them as people and as people who have choice. And when you tell me that people say, I don't know what to do, it's because they're not used to being given choice, not used to being given agency. So the role of the clinician in this situation is to say, I recognize that, but I also want to help you so that you feel less able to make a choice, because I think it's important that you are part of this decision. So in a way, it's about addressing democracy in healthcare. It's quite a deep issue, right? So I'm saying to you, we have treatment, we have a situation where we have more than one possible good choice. Both are okay. One has this advantage, but the other one has this advantage. This one has this harm, and this one has this harm. The probabilities of those things happening are slightly different, so I'm going to try and explain those things to you. You know, the classic example I use, and it's one I know well, and I think it's relevant to this audience, is a woman gets diagnosed with early stage breast cancer. This can happen at the age of, if you're really unfortunate, as early as 30, but it typically happens in the late 40s, 50s, 60s. Early stage breast cancer, stage 1. In that situation, the news is devastating. Oh, I have breast cancer. But quickly on the back of that news comes a really important surgical decision usually. Should I have a mastectomy, where the breast is removed, or should I have a lumpectomy and radiotherapy? Two big different surgical decisions. And what surprises patients often is that the long-term outcome of either surgery is the same, right? It's not that one surgical approach has major benefits in terms of survival. It's more or less the same. And so in that situation where the outcome is similar, what's left for the decision? Is it the view of the surgeon, or is it the view of the woman? In the past, it would be the view of the surgeon. And going back 20 or 30 years, it was definitely the view of the surgeons, which is why in the 70s, 60s, 70s, 80s, most women were given mastectomies. No choice. So what happened is that people began to realize that maybe there was a less drastic surgery possible, which is just to take the lump away and then to irradiate the breast with radiotherapy for about 5 or 6 weeks. And they discovered that actually the long-term outcomes were not that different. So actually women said, you know, we deserve a choice here. Some more assertive women said, hang on a moment, I want to have a choice. And between the women asking for choice and some surgeons saying, oh, maybe this is a situation where I should offer choice, the whole field changed. And now many more women have lumpectomy than have mastectomy. In fact, it's actually becoming a little bit rare for somebody to have a mastectomy. So the whole field changed. What's interesting, I think, is that the role of patient preference is still important. But you need a surgeon to recognize that there are alternatives. In some surgical centers, they are now measured on the number of lumpectomies they do, and they are punished if they do too many mastectomies. And so offering patient choice damages their numbers. But I still think it's quite important to recognize that a person who is in their late 60s, who has a preference for a mastectomy, should be given that choice. Because it may be that they don't have much transport, they don't want a reconstruction of the breast, and they want the minimal amount of surgical follow-up. So a mastectomy, and some women, even if they have a family risk of breast cancer going back into their mother or their grandmother, they say, I want to go flat. I want to take both breasts away because I want to reduce the risk of cancer in the other breast. So it's really quite an interesting area where the choice of the woman is really quite important. But my point is that unless the surgeons and the surgical team recognize that alternatives exist, shared decision-making will rarely happen. So this is where deliberation starts, right? If you don't become aware of choice, either on the clinician side or the patient side, this process doesn't start at all. So team talk, as I mentioned, is about that first step of saying to a person, we have reasonable choices here, A or B, and I'm going to support you to consider them carefully and to work with me and your family to make the right choice. I'm giving you an invitation and I'm going to support you. So that's the recognizing alternatives. And the second stage that almost automatically follows from that is, if we are going to do that work, we have to compare them. And comparing is really difficult because most patients don't live in this world of medicine, right? It's a very unfamiliar world for them. The world of randomized trials or clinical experiments is not where they live. And probabilities, statistical probabilities of 1 in 100, 2 in 100, 5 in 100, 10 in 100, it's often a foreign language to them. If you dare to use odds ratios or relative risk, you would lose them immediately. So you have to use numbers in a very simple way. And the simplest way of using numbers is to use natural frequency. 1 in 100 persons get this. Not 1 in 5, not 1 in 6, not 1 in 10. 1 in 100 is probably the best and easiest way. But you have to keep the denominator, the 100, the same all the time. If you say 1 in 50 and then 2 in 100, people get confused very quickly. So the denominator has to say the same. So comparing learning, comparative learning, is about communication, but it's also about these details of risk communication. How do you communicate probabilities in a way that the general public can understand? If you're a person who bets on the horses, they can do it. Betting on horses teaches you probability very quickly. But not everybody bets on horses, or bets, or gambles. All right, recognizing alternatives, comparing alternatives, comparative learning, and then this preference construction. Psychologists used to say that it's called preference elicitation, that technical term of eliciting preference. And psychologists then said, not really. People don't have preferences inside their head. They don't have them, especially for things that are new to them. You construct a preference. You make it up as you learn more about the alternatives. Oh, so having a mastectomy means 1 surgery and a drain and maybe about a week or 2 of surgical, and then I don't need to come back. Is that right? Yeah, that's right. Do I have to have a reconstruction? No, you don't have to have a reconstruction. You can have a prosthesis or a reconstruction, but you don't have to. So what does a lumpectomy mean? Well, a lumpectomy means that a much smaller surgery. We check the margins for the cancer, whether it's there or not, whether we got it all out. And then we give you doses of radiotherapy for about 5 weeks. Are there any problems with the radiotherapy? Yes, there are. It shrinks, it's tender, you have a bit of scarring. Oh, do you feel ill? Yeah, you feel a little ill with radiotherapy, high doses. You feel ill for about 5 to 6 weeks. Oh, okay. Having heard all of that, I am now constructing my preference. I am 60 years old. I don't really care about my appearance anymore. I would rather have minimal risk of complications of surgery. So I think for me, it's the mastectomy. Or I think I really want to look good. I want to look the same for my partner. I want a lumpectomy and radiotherapy. That gives me the highest chance of having a good self-image. So preferences are constructed. And people need time to construct those preferences, right? They need to think through it and maybe then don't talk to their families. So this preference construction is a process that takes time. And that's why your question over there about 3 minutes is really problematic. Try to imagine doing that in 3 minutes. I've already talked for about, 10, 15 minutes. Just imagine doing that in 3 minutes. I don't think it's really possible. So we need a more humane way of somebody dealing with the surgical choice for that. And that's just one example, one decision, right? And then, as a clinician, I say, okay, so I think I've understood you. You don't have any transport. You don't have anybody to bring you to the hospital. You're actually pretty poor, and you don't want to spend your money on taxis. So I think, given your situation and your circumstances, and what I hear from you, do you think that we should go with a mastectomy, or do you prefer the other approach? And then I go silent. I wait. Do you have any other questions? Right? I will know from the questions I get asked which way this patient is beginning to think, right? So that's the preference integration. Can I manage to do the best thing that this patient is letting me know that they prefer? They may not even say, I prefer this, but they will give me some indication of which way they're leaning. Probably, I hope. But you know, life is complicated, right? There's a context. They are emotional. Their family is upset, there are constraints, and there are social norms. This person is from a background where they never used to make a decision. They don't really know how to have agency in their lives. So I need to respect that. And last thing I'm going to do is to abandon them to feel bad about this decision. That's the last thing I'm going to do. Even if it means that I think, here I have to probably make a decision for this person, because they are struggling, and I don't want to abandon them. But that's okay, because the next patient will have more agency, and I will respect that. So I'm going to be very flexible, right? I'm not going to say I take the same approach to every patient. All right, so that's the theory behind this. When I said I need to teach this to people, I started to simplify it, right? And so I made this diagram. So basically, the process is about taking people on a journey from initial preference to informed preference. Taking them on a gentle journey, holding their hand, I hope, so that they feel good about it, right? And I simplified it into that. I made this diagram so that I say, okay, so when you're teaching somebody, let's take through the steps. And there are, although it's 3 things, there's more complicated things underneath, right? I happen to find it difficult to remember more than 3 things at once. So I gave myself the task of saying there are different things that fit underneath these things. Team talk is also about identifying those goals. Because behind the goals lie a person's life world. What Mischler, I think he was a sociologist, called the life world of the patient. What's it like to be a patient like that? And you've heard this before, so let me go here for a moment. The BMJ, when I managed to publish the second version of this, made this diagram, which I'm not sure about, actually, but they made it, the graphic designers there, and I kind of think, okay, and I think it's been helpful, because it is a bit of a circular process, right? Especially if you have more than one visit. And so there's this cartoon again. So let's work as a team. We had a bit of a debate about whether we should use team. And people say, what do you mean team? Well, what I mean by team is that I want it to be more than just you and me. I want it to be about you, your family, and me. Because I recognize that there's more in your life than just my view as a clinician. You're going to have to talk to other people. And this is where that issue of taking it back into another discussion means that there's a team approach here. I recognize that it's not just you alone, that you're going to have to involve your family here. And that requires usually another process or a second visit, or at least a time for you to talk to them on the phone or something. And then let's talk about goals. And I've already mentioned these 3 levels of goals, right? Remember them? Symptom, function, foundational, or life goals. If I'm really curious about you, and I ask about, you have knee pain, I hear, right? You have knee pain in your knee. Would you like me to give you something to help with your knee pain? Pain in your knee? Would you want some treatment? You would like that? You want something? So tell me what you cannot do because of this knee pain. Why does it bother you? You're a tennis player, I hear. Is that right? Is that right? You're a very good tennis player, right? We should play sometime, right? So it bothers you. You cannot play tennis. Is that right? Yeah. Okay. And I know why you play tennis. Because you want to meet somebody in the tennis club, right? Because you have a very good social life in the tennis club. Is that right? Am I correct? I'm embarrassing him. But basically, his knee pain involves much more than having a pain in his knee. He really likes to play tennis, and he really likes to play tennis because it amplifies his social life. It makes his life worth living, right? So now I've understood what it is about knee pain for this person. So I'm going to be really careful that what I would like to do is to give him a treatment that makes sure that he plays tennis as much as he possibly can. Right? I don't want to disrupt that. In fact, I probably will say, we maybe need some physiotherapy here to strengthen your leg, because that will help you with your tennis, not just a non-steroidal anti-inflammatory that I would automatically probably try, right? So because now I know about his goals, he wants a social life, he wants to get good at tennis, get rid of his knee pain, I've understood this person a little bit better, right? That is the beginning bit of the talk. And I don't know you very well yet, but I think if I bothered to understand what's important to him and his life, he will probably say, this is an okay kind of clinician. He has bothered to find out what's important to me. I will be prepared to work with this person. Right? So it builds a relationship, and it builds that magic stuff called trust. That magic ingredient. Okay. Yeah, so we wrote about these. And I think they happen to be very important for clinical medicine. This is the option talk. Let's look at the options. And here it matters that I love the question. I think you or us, who was asking it? How do you avoid giving your impression of what's the best thing to do, right? How do you reserve your judgment? You don't influence the patient too much. I think it's impossible not to portray some of your views, but at least you should say, let's make a list. There are A, B, and C. There's mastectomy or there's lumpectomy with radiotherapy. These are the two. And then after you've they've understood that there are 2 or 3 options, let's now go into detail about each one. Let's take this one first and describe it. Let's do this one second and describe it. If you have a third one, let's do this one. And I think it really helps to take a piece of paper or use a patient decision aid to say, let's put them in front of you, write them out so that we say we are in the process of comparing A and B and C. So you make it visual because it's easy for people to get confused about what are we doing here? Are you giving me a lot of information and I'm getting confused quickly? So keep it simple, keep it clear, maybe draw it out so that people understand what you're comparing. And there's a lot of papers written about risk communication. How do you talk about probabilities? The positive framing. If I say to you, one person has this side effect in 100 people, it's very different if I say 99 people don't have a side effect in this situation. So if I want to persuade you to take this, I'd say 99 people, no problem at all. Or if I want to scare you, I might say, you know, 1 person every 100 has this side effect. A very different interpretation of the risk, right? So framing positively, 99 have no problem, or framing negatively, 1 person have a problem, is a very different way of conveying information. So framing, and then the probabilities using natural frequency, 1 person in 100, versus giving you an odds ratio or a relative risk. These are the kinds of skills that clinicians need to know about. Risk communication. There are so many papers about how to do it well. But here's what my friend Paul Gulbrandsen from Norway says about this. Really be careful about information overload. People can only remember so much, especially if they're new to this kind of problem. So keep your information slow, in chunks, and check for understanding. So slowing it down, giving information in chunks, checking that you've understood. These are not things you can do at speed, right? They just slow things down. Oh, you have a translation. Nice. Is it good? Is it good? Wow. All right. And then this last thing, which is really about this magic, another magic. Trust is one piece of magic, but the other magical word that I like to use is curiosity, right? If I'm curious about what you're now thinking, that's going to really change the feeling in the room, right? I've told you a lot of stuff about these 2 choices. It's probably new to you, and I'm really interested to know what you're making of this, what questions you have, what worries you have, what concerns you have, what haven't you understood? And then I go quiet. I go quiet long enough for that person to feel, they're really interested in what I have to say. And you know, I've been studying how long it is that people pause between talking in turns. You know, turn taking. We speak with one another and then you pause for the other person to speak. The gap between you stopping and me speaking and vice versa It's very narrow. It's 0.2 of a second. So it's 0.2 of a second in most situations. We speak pretty quickly and we don't give each other many pauses. But a pause that goes beyond 0.2 is very important, because what people then notice is, you're pausing in an asymmetrical situation. So what I mean by asymmetrical is, if you and I were friends and we know each other, we would only use 0.2 of a second as a signal, it's your turn, or it's my turn. But when you're in an asymmetrical situation, clinician and patient, with lots of power differential, then the gap between me stopping and you speaking has to be longer than 0.2 of a second. I have to pause for longer. And the problem with many clinicians is that they ask a question, say, what do you think? And they start talking before you have any chance to say anything. So if I start talking before you have any chance to respond, the signal to the patient is, they ask me a question, but they're not really interested in the answer. And that's a critical bit of clinical communication that clinicians often do not have any feedback about. So in this process, I ask the question, which is very simple for me to learn. Oh, tell me what matters most to you. And I keep on talking, and I never give you a chance to answer. I never learn what's important to you. If I'm going to ask that question, tell me what's important to you, I have to stop. I have to stop talking. And the patient will feel uncomfortable and say, oh, geez, I have to say something. Oh, yes, you do. But I'm going to try and make it easy for you, right? Because I'm going to say, you've gone silent for about 10 seconds. Then I'm going to encourage you to say, you seem hesitant to tell me what you're thinking. I don't ask another question. I just ask a follow-up question which says, tell me what you're thinking. Tell me what your concerns are. You seem worried. Tell me. So, in other words, I follow up with a question that doesn't take the conversation in another direction, because I come back to this question. What matters to you? Tell me what you're thinking. And it takes a lot of skill to change your habits. Clinicians don't grow up with these habits. They watch other clinicians and they don't see this happening. So they role model on other behaviors. So to do this, like the 24 champions I interviewed, takes a lot of deliberative skill building. You need to change your habits. So we're going to do that, actually. This is more about goals. In other words, goals fit in every step. I'm not going to go there. All right, so let's try this. Let's imagine that one of you, form pairs, that will need some movement, right? So you need two people to form a pair. I would like you to imagine that one of you is a patient, one of you is a clinician. I would like you to agree a situation where there's more than one reason why. It can be anything. You can be even talking about a phone or a car. It doesn't have to be healthcare, right? If you want it to be healthcare, that's okay. You can have it about yourself or your patient, vice versa. It can also be something that you make up. Not to be. What I'd like you to do is to do team talk. You remember the steps? We have a situation with our reasonable choices. I'm going to support you. And by the way, I want to hear your goal. So those only two things. So form pairs, and let's do it for about, let's say, 4 times. Off you go. Find some quote. Okay. Okay, you can stay where you are. No, stay where you are. There's more work coming. Okay, well, thank you very much for agreeing to do that. I want to just get a bit of feedback from you. The two things, which is to say, we have some choices, I want to support you, and what are your goals? How is it going? Any feedback to me? Was it easy? Was it difficult? You're still going? Are you only beginning? No, you're going too fast. But what you noticed is it takes time, huh? It takes time. You noticed that? Much more time, okay. So this task was about saying that there are choices and I'm interested in your goals. How did it go, other people? How did it go? Did it go well? Yeah, go on. Please, go ahead.
Thank you. Due to time constraint, we couldn't really finish up the talk. But first of all, I took a role of patient and
Yes.
she took a role of doctor.
Yes.
And we made a situation where psychiatric patient has to choose between option 1. She can admit to the hospital.
Yeah.
Option 2, she can just stay at home and take the medicine.
Okay.
Yeah. And she has a thought of suicidal thought.
Okay, complicated.
Even though we couldn't really finish the talk, but still, our doctor asks patients which way you really prefer.
Okay.
What is your goal? What is your lifestyle?
Okay.
Yeah, that got me thinking that, she really concerned about my lifestyle and she tried to empower me. So that was kind of something.
So your clinician was beginning to ask you about your goals.
Right.
Right, okay. Did other people get to the goal talk? Anybody? Yes, here. Yes, go ahead.
We made a situation not related to the medical decision.
Sure.
Actually, we are talking about working late after the work hours. It's not for my professor to hear, just to let you know. Yeah. But, or just finish work on time.
Sure.
But my patient was very certain mind to work until late because she has something due date or something like that.
Yeah.
So it was very hard to talk with the goal talk because she has a one certain mind to work late.
Right.
So just
no, I understand. But you got to some goals. You were beginning to understand her goals.
She said that she doesn't want to get stressed, but she wants to work until late. So I don't know what to do.
Very good. All right. So here, it's the beginning of this process, right? You're going to form a team. I'm going to help you. And I want to be interested in who you are, what your goals are. It's a little artificial, I know. But here we were talking about team talk, that beginning phase, right? What's interesting is that I think it's very difficult to separate out different steps, right? When you begin to say there are different choices, it's quickly going into the other complicated areas about, so tell me your views. Okay. So now I would like you to repeat that a little bit. This is the last exercise. We can do the 3 things. So, would you like to do option talk, or would you like to do decision talk, where you elicit the preference? I think you should probably do option talk, where you say, let's describe the options. Let's go into detail about the different choices. In your situations, you could say, stop working. Don't worry about the deadline. What alternatives have you got? Or you could say, if you're going to meet the deadline, what else goes What are the other sacrifices you are making? So those are the two options. In your situation, is staying at home or going to hospital, right? And so, I don't know what you were talking about. What were the choices you were talking about? Do you want to share, or is it too private?
Well, please understand, I'm not physician or I'm not clinician. So, yes, I will try to describe this complex situation. We decided, treatment situation for,
Sure.
yes, rheumatism drug. Is it right? Rheumatism, in Korean term, rheumatism.
Rheumatism?
Yes, rheumatism.
Okay,
Yes,
okay,
rheumatism
sure.
drugs. So,
Sure. So you're comparing two treatments for rheumatoid
yes,
problems?
yes.
Okay.
I realized that we tried to option talk or decision talk in our previous time because
Sure.
she described two options for me because
Okay.
even though I'm not, physician,
Okay.
first option was injection.
Yeah.
Yes.
Injection. Yeah.
Second option was drug. Is it right?
Okay. Okay.
Yeah.
So she already got to option talk.
Yes,
Yes,
right.
yeah, sure.
Yes.
No problem. So let's go there. Whatever your situation was, I would like you to do option talk. So you can use Gemini or something to, you need more information about the options, okay? You can find it pretty quickly. It's not going to be perfect, but that's okay. But basically provide brief details of the harms and benefits. And I would like your patient to think carefully about how skillfully you are giving them the description of the options. So go ahead for doing that for about 3 or 4 minutes now. Okay. So let me ask you to come back together again. Thank you for taking part in that again. I'm not sure how far you got, but would you like to share with me what did it feel like to be the patient? Who was the patient in this situation? Who was the patient? Anybody? Who was the patient role here? You were the patient role? Would you like to tell me what it felt like to hear about all these options? And what were you describing?
We just set the scenario, like if I am the migraine patient.
Migraine, yeah.
And then I ask her, like, what kind of medication or is there any way I can have for better days? And she really played good doctor role. And then she explained about the pros and cons of medication. And at the same time, like preventive medication, was it the injection? Yeah, anyway, she explained well. And then by listening to her recommendation, actually, I wanted to know if I were her family members, what kind of method would you really recommend? Yes.
Right, so you asked her to recommend the treatment.
Oh, yeah.
Yeah, sure.
So, yeah.
Can I ask you a follow-on question? How did it feel to be part of this process of being given information about treatment choices?
Yes, like giving very precise information is a really important part, but sometimes like too much information or information with uncertainties may make us really confused. Yeah, so there will be sometimes like unintended effect of shared decision making.
Yeah.
Mm-hmm.
So this is really important comment here. So volume of information, a large amount of information is hard, right?
Yeah, it's really hard.
And information where the clinician is saying, this is not certain, also hard. Is that right?
Yes, right. Mm-hmm.
Has anybody else got this situation where, it's becoming a bit confusing because of giving information about choices? There's a nod over there. I can see somebody nodding. And I think this is true. A lot of information can be confusing. Information about uncertainty can make you uncomfortable, actually.
Yes, right.
So these are the problems of giving information about choices. Too much and uncertainty. But here's the interesting thing, that medicine is really full of uncertainties. If you are being honest, then you are always having to talk about uncertainties at different levels, right? Uncertain because we don't have information. We just do not have it. There has not been any scientific study, so we just don't know. Patients find that difficult to understand, actually. They don't believe you. Really? There hasn't been any good information about this? Yes, really. Not enough scientific work has been done. So that level of honesty about it's still uncertain can be really difficult for patients. They think that we know what we're doing all the time, but that's not true, right? And so the degree of honesty and transparency can be really difficult for patients. And sometimes we try and convey certainty where it doesn't really exist. And we are being a little bit dishonest, right? And so how much you can be kind, but also convey, we don't really know exactly the right answer here, but it's okay. I think we know enough to say that this is probably okay, but we don't know exactly how it will work or how often it will work. So acknowledging uncertainty, but also reassuring, is a skill. Providing the right amount of information is another skill. If you talk for many minutes about lots of detail, you overwhelm the patient and they get confused, right? And so the trick about communicating options is to give what people call gist information, small amounts of information that convey the right amount of detail for what the patient can digest. So anybody else in the patient side of the conversations that wants to share how they felt? Anybody? You were very busy talking. What happened? Who wants to share? How you noticed how long I wait? Who wants to share? Yes.
So I wasn't the patient side, but I used the Gemini as you suggested, and actually it helps a lot because we are talking the general issues, which is quite easy enough to discuss, but at the same time, it's very hard to make the benefits and harms from the each options. But when I asked to Gemini or the AI, the similar one, it summarized the pros and cons.
Right.
Exactly right, with appropriate amount of the information. I think it's very helpful.
Interesting, right?
Yes.
It did a pretty good job. Probably not many numbers. Is that right? It just summarized information. You could ask for more numbers, actually, eventually. You could push it a little bit, right? You ask another prompt. But this is also what I found, that if you are in a new area where you don't know very much, you can ask the large language models to summarize the treatment options.
Sometimes as the profession, you confuse yourself there, what I'm going to say, but it summarizes it and it helps a lot to explain it.
So not only were you doing that, but patients are doing this all the time now. So when they come to the clinician to say, oh, they already have read that. They don't tell you, but they have already read it. Most of them, not everybody. Many people are doing that, right? Anybody else wants to share their experience in a pair? How did it go on the psychiatry side?
So caring and concerned about my business and my lifestyle.
How did it feel?
Oh, I feel very supportive.
Okay.
She's been very supportive,
Yeah.
and very like listening carefully about what matters the most to me.
Yeah.
So we've arrived at a conclusion that, I really put an emphasis on like ritual, like going to church.
Okay.
So we've decided not to admit to the hospital.
Okay.
Yeah.
Okay. So I'm going to ask you, maybe it was the first time you experienced that, but how did it feel? Take the mic. How did it feel?
I feel well listened.
Mm-hmm.
Yeah. And she's really...
Yeah, go on. Please take the mic.
Yes. Can I add a comment as a clinician? Because I've been working as a psychiatric nurse, but then, and also at the same time, I was kind of a little bit of skeptical about applying SDM because of like mental capacity and other. But by just talking to her and exploring about the preference and explaining the options, and I feel really connected to her. Mm-hmm. And then I feel like I'm empowering her. Mm-hmm. So that was quite different from therapeutic communication that I have used.
Okay.
So it was very interesting experience.
Right. So what I think I'm hearing from you is that it felt okay for you too. It felt good for you. Did it feel good for you as a patient? Sure. Okay, good. Anybody else want to share that experience? Do you want to? Yes, I see you do. Microphone is coming. I'm very good at reading body language.
We conduct a role-playing exercise as dementia caregiver.
Dementia, yeah.
Yeah, dementia caregiver and she clinician.
You are the caregiver?
Yes.
Yeah.
Because we study dementia care part.
Yeah.
My professor. I took up the rule of dementia caregiver, and my scenario was to make a decision about whether to place a familiar member with dementia in a care facility or continue caring for them at home. Mm-hmm. My clinician listened carefully to my opinion as we talked. It became easier for me to make a decision because she gave me a lot of options and listened carefully. So I make a decision easily.
Okay.
Yes.
How did it feel to you as a caregiver? Did you feel okay or feel bad?
Really difficult because I'm not have dementia people. Sorry, I'm not good at speaking English.
Yeah, don't worry about that. Yeah, but did it feel okay or feel very difficult?
Very difficult.
Very difficult.
Because I'm studying dementia only.
Oh, okay.
Yes,
okay.
not have family caregiver.
Yeah, go on.
Add one more thing. Before we talk about decision or option, she's kind of very confident. I would like to my mom to go to care facility. Mm-hmm. She thought my mom will prefer because she don't want to family caregiver have some suffering.
I see.
And she also said the care facility is good for her, for safety and for her health. But after we discussion and we sharing other options, she feel more confused.
Oh, okay. More confused.
Why? Because she has more confident people about care facility, but after discussion,
more confused.
Facility.
So this is a common problem, actually. That as you give people choice in the early stage, people become more confused. Say, oh, I did not realize that there was these pros and cons to the decisions. I really did not know. I had made the assumption that this was the best way. Now it's more confusing for me. Because I know more about A and B, and suddenly I am more confused. So there's a short-term problem, right? You share decisions with patients, you will end up with people saying, oh, I am in more difficulty. And again, this is part of the problem. But I think that we're going back now to team talk. As people become more confused, they need more support. It's okay to feel confused because this is a difficult situation. Sending your relative to a care home or not is really emotional for both of you and for your family. So it's okay to think carefully, because if we make the right choice here, in the long term, you will feel good. You will have less regret. And this is the prize, right? This is the reward, that by spending time collaborating, as you did, and deliberating carefully, you will end up, but it takes a little bit more time, in a much better place, right? So the 3-talk model is a too simple model, too simple by far, because behind it is a lot of complicated human communication, right? But the process in the short term leads to more confusion, more problems. In the longer term, there's a reward. It's just like doing shared decision-making at the system level. In the short term, it's going to take more time. There is absolutely no doubt in my mind. You will hear some people in this field saying it doesn't take more time. I don't believe them. I don't believe them at all. Doing this well takes more time. But the reward for patients, for clinicians, and for health systems is big. We just haven't realized it yet, right? It's, what is it? 12 o'clock. I'm going to stop talking. You're going to have lunch. Thank you so much.